Good afternoon. I'm Serena Collado, Director of Community Health at Robert Wood Johnson University Hospital, Somerset. Thank you for joining us today for our webinar on uterine fibroids, presented in collaborations with Friends Health Connection. Uterine fibroids are non-cancerous growths in the uterus. Many don't cause symptoms, but some can lead to severe pain and bleeding and affect a woman's quality of life. On today's webinar, we will learn more about uterine fibroids, their causes, risk factors, prevention, and treatment options, including non-surgical treatments. Our guest today is Dr. Pavan Khurana, Medical Director of Interventional Radiology at Robert Wood Johnson University Hospital, Somerset. We will begin today's webinar with a 20-minute moderated discussion, and then we will open it up to questions from our audience. Dr. Khurana, thank you for joining us today. Why don't we start off by you telling us a little bit about yourself?
Okay, thanks so much for having me on today. I appreciate that. I'm an interventional radiologist. I trained at Cornell, and I've been here since my fellowship training for 7 years now. Our field, vascular interventional radiology, it's a field that specializes in minimally invasive procedures using imaging guidance, and we do a wide breadth of different procedures. Part of what we do is kind of like plumbing. The body is filled with pipes, arteries, veins, pipes between the kidney and the bladder, bile ducts and the liver. These are all pipes. Sometimes pipes get clogged. They need to be opened with balloons, angioplasty, stents. Sometimes these pipes leak, and we want to close them, and we have tools to do that too. Sometimes these pipes are feeding blood to tumors, and we want to stop the blood flow to those tumors, and we can do that as well. So that's one subset of what we do.
Oh, wonderful. Well, thank you so much for sharing a little bit about yourself with us. Now, why don't we start with just a general overview of uterine fibroids? What are they? What causes them? Why don't we begin there? Could you share a little bit on that?
Sure. So fibroids are very common, benign growths in the uterus. So when I say benign, that means that they're not cancer. And they're typically found in women between 30 and 50 years old by the time they present symptoms, if at all. But as you had mentioned earlier, fibroids don't always cause symptoms. In fact, very often they don't. So it's a very common issue, but for most people, they don't have any symptoms from them and they don't need any treatment for it. But for people who do have symptoms, those can be severe. They can affect their quality of life. And we have many treatment options nowadays to offer those individuals and help them to get back to their normal activity levels and normal lifestyles.
Wonderful. So now you said sometimes there aren't symptoms, but what are the symptoms of uterine fibroids?
Sure. So there's two major categories of symptoms. One is bulk-related symptoms, which is due to local mass effect from the fibroids. As they grow large, they can affect other structures nearby. This could be the bladder. So fibroids can grow large and press on the bladder, causing the urge to urinate frequently. Maybe you get up at night multiple times to urinate. That can be due to fibroids. They can cause pressure on the rectum, causing constipation. They can cause generalized pelvic pain, congestion, and bloating, usually worse around the time of your period. Those are some of the common bulk-related symptoms. The other category of symptoms is bleeding-related symptoms. So fibroids can cause bleeding, and that can be severe bleeding, even leading to anemia, which is low blood counts, which could require blood transfusions, could cause fatigue, but not all the time. The bleeding could be less severe, not causing anemia, but affecting the quality of life. And that, to me, is equally important. So just because it doesn't affect your hemoglobin number, the lab value, that doesn't mean it's not affecting you as a person. And it doesn't mean that it's not equally important to have that treated and evaluated if it's affecting your quality of life. So bleeding can be in between periods, or it could be very heavy periods, or it could be a combination of bleeding between periods continuously, intermittently, with heavy bleeding during your periods as well.
Okay. Thank you. So what are some of the complications that may be caused by uterine fibroids?
So the main things are their local mass effect. So we described a lot of the local symptoms that people could have. In terms of other complications, there are rarer entities. If the fibroid is located in a submucosal location, meaning it's against the birth canal of the uterus, it could, in theory, enter the birth canal and get stuck there. That's one possibility. And that could lead to some discharge or even possibly an infection, but these kinds of things are very uncommon. Even more rare, there's a rare risk of fibroids undergoing malignant transformation, or where the fibroid could actually turn into a cancer, but this is exceedingly rare, so much so that we don't, in practical terms, worry about that for people with fibroids. It's that rare.
Okay, sounds good. Well, is there anything that ladies can do to prevent uterine fibroids?
It's a good question. You know, to date, we don't know of any foods or lifestyle factors that would prevent the development of fibroids. Not to the best of my knowledge does that exist. We do know that they're more common, that there is a genetic component, and they are more common amongst African Americans. But in terms of preventing them from occurring, lifestyle modification-wise, there's nothing that we currently know about.
Okay, so how do you exactly then diagnose a uterine fibroid?
Right. So
especially if you're asymptomatic, right?
Yeah. Well, if you're asymptomatic, you may live your life without ever knowing that you had them. Typically, when a woman may first learn they have them, if they're not having symptoms, is if they're pregnant and you're looking at the baby and you see a fibroid in the uterus and you notice it incidentally, and it may be a small fibroid that's not causing symptoms. So very commonly, they're found incidentally on an ultrasound that was done for a different reason. Now, if you're having symptoms and your doctor is doing a physical exam, they may, based on your history, based on your symptoms, and based on your exam, they may be able to feel or palpate an enlarged uterus in the pelvis, and that might raise a flag for fibroids. Usually, if that's the suspicion, the next best test would be an ultrasound. That ultrasound can be done transabdominally, or it can be done transvaginally. Usually the transvaginal images will provide more detail as to the fibroids and their locations. And then other imaging options, there is a role for MRI at times if the ultrasound doesn't give us the complete amount of information that we need.
Okay, so as we know, there are many treatment options for uterine fibroids, including watchful waiting. So can you explain, when is watchful waiting a good option? And
Sure, yeah. So I think for that subset of people who are not really having symptoms, it makes sense that we would not treat them. If it's not bothering you, there's no need to fix it. We just leave it alone. Don't go looking for problems. It's kind of our motto. So in that case, we would just strictly observe them. For people with minor symptoms that they can deal with, that they're not really affecting their quality of life, that's another subset of people that probably also makes sense just to observe.
Okay, so let's talk about medications that are available out there. What are the medications, and are there, some that are more effective than others?
So medical therapy is probably the least invasive treatment option. So for people who are having mild to moderate degree of symptoms, that makes sense. Oral contraceptives would be the mainstay of treatment that can help to control bleeding symptoms. So estrogen and progesterone therapies are the mainstay of treatment, and that can help to control some of the bleeding symptoms, that can help control some of the bulk-related symptoms as well. So that would be the main medications that we would use.
Okay, so when should surgery be considered? Is surgery ever considered?
Of course, yeah. So surgical options would be on the other end of the spectrum. So they would be the most invasive treatment option. And there are different surgeries to be considered. So hysterectomy where we take the uterus out, or your gynecologist would do that in consultation with you. And that would, myomectomy is another procedure that they offer, where they take out fibroids from the muscle layer of the uterus. So for fibroids that are located in the muscle layer, that would make sense. And that's a less invasive procedure that allows women to keep her uterus. So basically, if there are bulk-related symptoms, or if you're, we'll come back to that question actually again later. I want to circle back to it. I'll tell you when I think surgery makes more sense for someone. But basically, that's, if you just want to have this treatment, this problem cured, you want to take the uterus out and be done with it and not worry about it anymore, that would be an option.
Okay. So, I mean, we talked about surgical intervention. What are some of the non-surgical options for uterine fibroids?
So in between medical therapy and surgical therapy, we would consider these minimally invasive therapies. Uterine fibroid embolization or uterine artery embolization, that would be one of the main treatment options to be considered kind of in between medical therapy and surgical therapy. So it's a uniquely effective procedure for bleeding because we're actually stopping the blood flow to the fibroids. It's done with X-ray guidance, low-dose X-ray guidance called fluoroscopy. And it involves putting a catheter into the artery, the groin, and then moving that catheter into the uterine arteries, where we inject biologically inert, microscopically small particles to stop the blood flow to the fibroids. The fibroids are then deprived of the oxygen and nutrients that they need to live, and they shrink and scar down. So it causes shrinkage of the fibroids, but it also stops a lot of the blood flow to the fibroids and uterus itself, and thereby is extremely effective at controlling bleeding symptoms, and is also highly effective at controlling bulk-related symptoms.
Okay, thank you. So is there any chance that a fibroid could, come back after you've treated it? Typically the situation is not that the fibroids come back or return, but it's that new fibroids can continue to develop. Usually for people in the 35 to 50 age group, that's less common of an issue. The closer you are to menopause, the less likely it is that you'll develop new fibroids, but it is possible to develop new fibroids regardless of the treatment option that you undergo, unless of course you undergo a hysterectomy in which the uterus is removed, then you wouldn't have to worry about that. Okay, so as far as treatments were concerned, we talked about, surgical interventions, non-surgical interventions, medications. Was there any other treatment options that we missed? Because I know you wanted to circle back on something.
Right, yes. So, we discussed medical therapy. I think the next step up is considering uterine artery embolization where appropriate for an appropriate subset of patients, usually ages 35 to 50. There are a small percentage of patients who have bulk-related symptoms the procedure is effective for about 90% of patients with bulk-related symptoms. So that means there's about 10% of patients who may still continue to experience bulk-related discomfort after a uterine artery embolization. For those patients, they may go on to have a hysterectomy. So those are the patients where you might consider, I don't want to undergo 2 procedures, let me just have a hysterectomy. But it's 90% effective for bulk-related symptoms, and it's close to 100% effective for bleeding symptoms. So depending on the scenario and in consultation with your doctor, you would find the best treatment option that makes sense for you.
Okay. So maybe if you could share, without naming names, can you share like a recent story about a patient who had a uterine fibroid embolization?
Sure. I did have someone just recently I saw in our office. Very lovely 42-year-old woman. She has 3 children, job, family, doing the whole thing, busy mother, working, and her life was severely impacted by her bleeding symptoms. She was having bleeding every day. She was having very heavy bleeding, sometimes even to the point where she couldn't get into work because it was just going through 10, 12 pads, changing every 1 to 2 hours. It became an unpractical way to live. And interestingly, her blood counts were normal. so she was not anemic, so she didn't require blood transfusions. But this was one of those cases where her bleeding was so severe that just because her numbers didn't show anemia, that doesn't mean that it wasn't important to treat her and get her back to the quality of life that she's used to enjoying. So we did proceed with the fibroid embolization for her. She did it amazingly well. She was back to work after a few days. I think we did her procedure on a Friday. She was back to work the following week, and had no more bleeding symptoms, just back to her normal life. So, it's a good option in scenarios such as that, just for a quick return to get back to the life, get back to what's important.
Wonderful, great story. So should somebody actually suspect that they might have uterine fibroids, what is the first step that they take? Which do they call their primary? Do they call, a gynecologist? What is your recommendation?
Sure. So typically we work closely with patients' gynecologists. They'll go review the treatment options, and I think that's usually the best place for them to start with their GYN. Of course, we're always happy. I do occasionally see patients who haven't been to their GYN for a few years, but they've had a family friend or they know they have fibroids based on a prior ultrasound, and we're happy to see them as well. So either way is okay with us, but we do work closely with their gynecologists all the time.
Okay, very good. So at this time, I would like to open it up to questions from our audience. So for our listening audience, if you do have any questions for Dr. Khurana, in the group chat, you can type your questions and we will field them and ask the doctor. So I know one of the things that I commonly hear sometimes in the community is that, sometimes women will say to me, hey, I've heard yes, like you had mentioned, uterine fibroids can push out your stomach and sometimes maybe even make you look pregnant or you have that pot belly. So how does a woman differentiate, visceral fat or stomach fat versus, a uterine pushing out a stomach?
That's a great question. That can be difficult at times. And, a physical exam can help where you palpate the uterus and you actually feel it, which will have, usually it's harder, whereas visceral fat will be a little bit softer compared to the uterus enlarged by fibroids. And short of a physical exam, the next step would be an ultrasound to diagnose the presence of fibroids, and that can tell you how big they are. And, if you have small fibroids that are unlikely to be causing to the protrusion of the abdomen, or if you have very large fibroids, which can cause significant abdominal protrusion and girth. So an ultrasound would be the way to definitively identify that.
Okay. So one of our first questions from our audience members is, how common are uterine fibroids among young women?
They're very common and mostly, again, asymptomatic, and we don't know because we don't screen everyone with ultrasound to see who has fibroids, but it's an extremely common thing to have. And for most people, they don't even cause symptoms. You don't know that you had them. They're small and they go away. We know they're more common amongst African-American females, usually 35 to 50 are the most common age categories.
Okay. Another excellent question from our audience member would be, would a patient need to fail medication intervention first in order to be eligible for the minimally invasive procedures that you had talked about earlier?
That's actually a great question. So no, we offer information and options, and we encourage a dialogue, and every patient should have a dialogue with their doctor and figure out what is the best treatment option that makes sense for you. So there's no one size fits all answer. And some people, medications don't make sense for if they have a history of blood clots or smoking history, and these medications can increase that risk. So it depends on the patient. It's very individual. Sometimes these medications can cause some side effects, and if you experience those side effects, that's not something you may want to do or use. So very dependent on the patient. Gynecologists can also work up their hormone levels throughout their menstrual cycle to see if certain hormones would make sense as a treatment option for them. So no, so not necessarily that you have to be on medical therapy first. It has to make sense for you.
Okay, great, thank you. So can you tell us, next question is, what is the recovery process like after getting a uterine fibroid removed?
Okay, good question. So after having a fibroid removed, so I'm assuming that means surgical removal of the fibroid, and that could be a myomectomy, which is a less invasive procedure where they take the fibroid out of the muscle layer, and women are typically back to their activity levels the following week, versus a hysterectomy, which is a more invasive surgery where their uterus is removed, and that can be a few weeks or several weeks by the time you recover and get back to your normal activity level. And everyone has a little bit of a different recovery process sooner or later. The uterine artery embolization procedure, recovery times tend to be faster. Usually people are back to their normal activities within 2 to 5 days and back to work within 1 to 2 weeks.
So it really depends on the procedure, which procedure they're having.
Correct.
Okay. So you mentioned ablations. Are ablations covered by, most insurance carriers? To your knowledge.
Right, yeah, so ablation, there's different types of ablation procedures, which we actually didn't really touch on today. But in general, treatment options for fibroids are covered by insurance companies if you're having symptoms from them.
So while we're on that topic, if you wouldn't mind, can you maybe elaborate on what the ablation procedures for uterine fibroid would be?
Sure. There's different types of ablation procedures. There's radiofrequency ablation and endometrial ablation. So sometimes these words get mixed up. I think one of the common procedures that's done for patients with heavy uterine bleeding, and I have a feeling this is what they're referring to, is endometrial ablation. And that can be done for dysfunctional uterine bleeding that's caused from endometrial hyperplasia, or when the inner lining of the uterus is bleeding abnormally, and that may or may not be related to fibroids. That can be used to treat fibroids sometimes if they're in a submucosal location, meaning that they're up against a birth canal. And then there's other types of ablation procedures as well. There's even high-frequency ultrasound and MR guided ablation procedures, but these are more experimental treatment options that we wouldn't get into.
Okay. So another good question from our audience member is, does ablation or embolization result in scarring? If so, can this be problematic for women who want to have children in the future?
That's a great question. So as far as uterine artery embolization is concerned, fibroid embolization, UAE, all the same thing. Yes, we don't recommend doing that procedure for women who are still looking to have children in the future. And the main reason is we don't know the viability of uterus's ability to have children after this type of procedure. So it's not recommended if you're still planning on having children. There are other treatment options, namely medical treatment options. Sometimes a myomectomy might be appropriate in that situation. So those are things that you can talk to your gynecologist.
Oh, good. So before I go on to the next question, just to kind of expand that, when we talk about endometriosis versus uterine fibroids, correct me if I'm wrong, both of them can be risk factors of infertility, correct?
They both can cause infertility, yes.
So if women are seeking to become pregnant, then they may need some type of intervention.
It's possible, yeah, and that would be part of a workup that they would undergo with their gynecologist or their obstetrician as needed. So it is possible, yes, it is a potential cause of infertility.
Okay. Thank you very much for clarifying. So can uterine fibroids develop into cancer if left untreated?
It is extremely rare. So there is a type of cancer called leiomyosarcoma, which can be from fibroids developing and having malignant transformation or cancerous transformation. It is extremely rare.
Oh, wow. Do you know what percentage of the patients can actually develop that?
Offhand, I think it's something like 1 in 30,000, like some very low number.
Okay. Yeah, I figured maybe we could give our audience just a little bit of, an idea of how frequent that does happen. So in most cases, again, please correct me if I'm wrong, that, many women live with uterine fibroids and go on for years having them, not ever knowing that they did. So there really isn't too many.
Typically, your gynecologist would order an ultrasound every couple of years just to make sure that the fibroid didn't start growing to an abnormal rate as compared to prior. And if there was significant growth in between, then they may consider looking into that further, either with a biopsy or possibly with.
Okay, very good. And I'm just looking. Oh, we got another.
That's for that. And just to clarify, that's typically in a postmenopausal patient. So we don't typically expect to see growth of a fibroid in someone after menopause.
Good to know. So if symptoms are moderate, would it be better to treat now or wait and see if it gets worse?
Great question. It really depends on how it's affecting your quality of life, and it's very individual. So, it sounds like if symptoms are moderate and you're kind of thinking about a wait and see approach, then perhaps it's not affecting your quality of life enough where you need to have treatment. So another option is to maybe do something less invasive, like discuss with your doctor, maybe medical therapies, maybe oral contraceptives, maybe hormone therapy. It's right in that category.
All right, so sounds good. So again, it really depends on the patient, or depends on the individual, depends on how it is affecting their quality of life.
I think that's the most important thing. We don't want to treat numbers. We don't want to treat size of a fibroid, hemoglobin levels. I think the most important thing is how is it affecting your quality of life. And that is the most important determining factor to work with the patient. If it affects you, then it's important. If your bleeding is severe to you, then it's severe to me. I don't need to quantify it in terms of a hemoglobin drop. I need to know how it's affecting you as a person. And that's the most important thing.
Great, thank you. That's a wonderful explanation. So I know we're just a few minutes shy of 12:30, so I just want to do final call for last minute questions. If you have any final questions for our physician today. So I want to certainly thank you, Dr. Khurana.
Thank you.
I really appreciate it. Okay, we have another question.
For sure.
So does having a chronic pain condition such as fibromyalgia or autoimmune disease impact the level of pain that one can experience from fibroids?
Yeah, that is a very good question. Certainly, those types of syndromes that you described, chronic pain, fibromyalgia, can cause hypersensitivity of the nerves, and that can be throughout the body, including the nerves, which innervate the uterus. So absolutely, there is a hypersensitivity, hyperactivity of the nervous system in those conditions that can cause increased pain levels. It's a great question.
Wonderful. Thank you so much. All righty. Well, I think that will conclude our question and answer session. So I'd again like to thank you for joining us today, everyone, and thank you, Dr. Khurana. Please remember that the opinions shared here today from our medical expert are not a substitute for medical advice from your own physician. If you need a physician, please call 1-888-724-7123. For more information about Robert Wood Johnson University Hospital Somerset, please visit www.rwjbh.org/Somerset. Thanks again for joining us, and have a great day.
Thank you.